Okay, good evening everyone, and welcome to the National Kidney Foundation of Wisconsin's program on living donation and kidney transplant. We're very excited tonight to offer this March's Kidney Month program with our good friends from the Aurora St. Luke's Solid Organ Abdominal Transplant Program. You're going to be hearing from a number of experts tonight. We're so happy that they volunteered their time to join us tonight. For those of you that are listening online, we have a very, very attentive and excited crew here in Franklin, Wisconsin at the Public Library. Just a few housekeeping notes. We have an awesome volunteer, Merle, who will be monitoring, for those of you that are online, any questions that you'd like to type in. Our guests here in the room will, assured me they're going to use their outdoor voices when they ask questions of our speakers, and our speakers, I think, will repeat our questions so everyone will be able to hear. We're recording this program, so don't worry if you might miss something or want to listen to something again or see the PowerPoint again, and we'll have that on the kidneywi.org website next week. I will, I think, turn this over then to Kathleen Springer, who helped coordinate this program, and I'm proud to say is a member of our board of directors, and she'll introduce our speakers tonight and start our program. So welcome, Kathleen.
Hi everybody, my name is Kathleen Springer. I'm the Manager of Business Operations for the Aurora St. Luke's Medical Center Transplantation Program, and I am honored not only to have all of you here present, but then all of you listening throughout the country. We are really pleased to be able to offer this information to you and welcome any type of questions. I wanted to thank Cindy and her team for the awesome support that she's offered us from the National Kidney Foundation of Wisconsin to allow us to bring this information to you. I'd like to take this opportunity to introduce those who are going to be speaking. It will be Dr. Fadi Hussein, who is a transplant nephrologist with Aurora. He's also the director of our Living Kidney Donor Program. In addition, you're going to be hearing from Jeff Klister, who is our Living Donor Nursing Coordinator. We also have Jessica Berger-Martinez, who is a social worker for the Kidney Transplant Program. And then we also have Chris Carloni, who is a transplant financial counselor that will be able to offer a lot of information for you. In addition, we have Kelly Fenhouse, who is a procurement nursing coordinator, who's the one who coordinates everything for the surgeries. So you'll, if you have any questions for her, she will be available to you as well. So at this point, I would like to welcome Dr. Fadi Hussein and start our program. Thank you very much.
Thank you, Kathleen, for the introduction, and thanks for everybody for arranging this. I know it took a lot of time from everybody to put everything together, a lot of invitations and emails, and thank you for being here. So who actually knows who we are from before? Okay, that's very good. And how did you hear about this? By the mail, okay. Facebook, okay. Anybody got an email? Email, okay, good. So, oh, okay. Is that?
And remember, you've got people from California to New York.
Sure. Is that better? Is that better? Okay, very good. So the way we are going to do this until we have the slides up is. So this, I don't want you just to look at the slides all the time. Look at me and ask me any questions, and you can interrupt me at any time. So I'm going to be talking about the medical part of living donation and the benefits of living donation compared to deceased donor. Okay, thank you. Compared to deceased donor kidneys, and then Jeff is going to talk about the evaluation process. So he's going to go over how we do it, what are the questions that we ask, what are the criteria for selection, and then he's going to talk about the tests that we do in order to evaluate the living donors. And then after that, we are going to be talking about the social aspects of that. So, so we have Jessica, who's going to be talking about that, and then we're going to talk about the financial part of it as well. And if you have any questions to any of us, just you can just stop me at any time. I have the slides just to show you a few things and numbers, but they're not intended to that. I don't want all your concentration to be on the slides. Okay. So so this is basically from the OPTN, which is an organization that evaluates all people who get organ transplants. So we're looking at everything here, not only kidneys. So there is 122,000 people waiting for life-saving organ transplants, and 80% are active on the waiting list. Of that, there is 100,000 that are waiting for kidney transplant. So if you are waiting for kidney transplant, you're not alone. There's a lot of people who are waiting for that. And the median wait time is almost 3.5 years, and that depends on the location. Different states and different, we call them OPOs for transplant, and that depends on how long their lists are and how fast they move. So in 2014, there was 17,000 kidney transplants that took place in the U.S. 11,000 came from deceased donors. Deceased donors, of course, when someone dies, there's 2 kidneys, so that's more supply there compared to living donors where you take 1 kidney, of course. And 5,000 came from living donors. So that is actually a significant number, that there is 5,000 living donors that happened that year, and that is not something to ignore. So every month there's 3,000 new patients are added to the kidney list, and 12 people unfortunately die waiting for life-saving kidney transplant. And most of these patients are actually been on the list for some time, and they're waiting for the transplants because they did not have a living donor, so they're waiting on the deceased donor waiting list. And unfortunately, a lot of these patients with time, because they've been on dialysis, they have a lot of medical problems, they might develop heart disease, or they might not be considered as potential recipients for transplants. And then there is every 14 minutes someone is added to the kidney transplant list. In 2014, 4,000 patients died while waiting for a kidney transplant, and another 3,000 became too sick to receive a kidney transplant. So despite the fact that we have that good number of living donors, we're still in need for more living donors. Now at the same time, on the other end, we are trying to increase the pool of the deceased donor kidneys that come from different places. So in order to do that, we are trying to accept kidneys that we didn't accept before, and there are different ways of trying to do that. And the new, we call it kidney allocation, which is basically how we, so if you have people on the waiting list, and then you have organs coming from people who are deceased. And then in order to get these kidneys and transplant more people, we are trying to accept more kidneys, and then we are trying to allocate the kidneys and matching them according to the recipient. So if a recipient, for example, if you have a recipient who's 20 years old, we would expect that they're going to live a very long time, so you would try to give them kidneys that are going to live much longer time. But if you transplant these kidneys into people who are sicker, and you would think that they're basically older, maybe 70 or something, so you don't give them a 20-year-old kidney. So trying to arrange for that, that's basically the new allocation system in simple terms. If anything is not clear, you can also stop me, okay? And I'll repeat the question so other people will hear it, because sometimes, we doctors talk, medical terms, and that sometimes is not, understandable, okay?
Dr. Hussein,
Yeah. Go ahead, yeah, please.
This is the first time that I've heard there's an active part of the people on waiting. So what makes something active or what makes it inactive?
Sure, okay. Yes, absolutely. So the question is that there are people who are active on the waiting list and people who are inactive on the waiting list. And the difference is people who are active are people who are ready to get a kidney transplant now. So people who have been evaluated and their evaluation is current, and they're in a good shape to get a transplant at any time. The people who are inactive are people who are considered for kidney transplant, but for some reason they have a certain medical condition that is temporary, so we put them on the inactive list until that temporary issue, whether that's a social issue or a medical issue, is resolved, and then they are active on the list again. Sure, no problem. So this basically looks at how many people have, and as you can see, the number is really increasing. Is that oh, there it is. Thank you. So you see that, sure. So in 1980, you see the numbers, and you see the numbers how they're increasing. Now, part of that is because of aging population, diet, increased risk for increased diabetes rates, and all of that. So a lot of people who are in need for kidney transplant. Now, the reason why I put this is this: the next slide here is looking at the people who are waiting, and you can see how the number is going up. And then those are the deceased donor organs transplanted, and those are the ones that are recovered. So basically, you have a stable number of organs that are provided, but then there's more people who are in need for kidney transplants, and that's why we need living kidney donation in order to supply the shortage. So, and those basically, this one will look at the survival of patients if they stayed on dialysis, if they stayed on dialysis, and compared if they got a transplant. And you can see how if you have 100 people and you follow them for 5 years, you see the numbers, you see the difference. So kidney transplant does save lives, and that the difference is profound compared to if they stayed on dialysis. So this is here if they stayed on dialysis. There's more people who are, not going to survive, and if they get a kidney transplant, their survival rate is much, much better. Now, this slide basically looks at the years since transplant, and you're looking at the survival of the kidneys. And this is the main thing about this one is comparing people who got a living donor kidney transplant compared to people who got a deceased donor kidney transplant. And you can see the difference here. So people who got a living donor kidney transplant, they actually do better, and they survive longer compared to people who got a deceased donor kidney transplant. And the reason why is because living kidneys are better. They work immediately. The risk of rejection is less because we have more time in order to evaluate their immune system and all that. And at the same time, these kidneys, when someone dies and you take the kidney, there's some damage that happens after that. And then when you transport that kidney in order to transplant it, then there will be some damage there as well. So this is basically looking at the survival of the kidney. So people who got a deceased donor kidney, the kidney might live, this is up to 15 years. However, a live kidney, this is a deceased donor kidney, a live kidney up to 26 years. So basically double the time. So a live kidney would last in the recipient double the time, and that's very significant and important here. And this slide will tell you about the differences between preemptive means that they got a transplant before they started on dialysis, and this one is if they are on dialysis for a year. So people who get a kidney transplant before they start on dialysis, on the long term, they do better than people who start on dialysis for more than a year and then get a kidney transplant after that. So this is looking at the number of kidney transplants that are basically done per year, and this will tell you the total number. This is basically the living kidneys. So there has been a rise and then a steady state after that. The deceased donor kidneys, there is still a rise, and that's because we changed how we allocate kidneys, so we tried to accept more kidneys that we didn't accept before. So who can donate? Live kidney donation for age is anyone from 18 to 70 years old. Of course, family members, friends, co-workers, neighbors, and church members, example potential donors. And what I wanted to say here is that it does not have to be the same blood type, because we can do exchanges, and we're going to talk about that. A lot of people ask me about that. What if they're a different blood type? We can still work around that, so that shouldn't be a problem. Now, people who cannot donate are people who are diagnosed by a medical professional, not like, someone tells you, well, I think my blood pressure is high, I have hypertension. It has to be a real diagnosis so that they know that they actually have that medical condition. So diabetes, kidney disease, of course, drug or alcohol abuse, and then heart disease, valve disease, lung disease, an HIV infection, recurrent blood clots, and smokers who must be tobacco-free 8 weeks prior to the donor surgery. Now, we're going to talk about the paired exchange donation. So that's basically if someone comes and says, I would like to donate to my brother, but then you look at their blood types, and the blood types are different. So what do we do here? Then we do the exchange, and this is a very simple thing. So if the donor is a husband and wants to donate to his wife, but for some reason there may be a different blood type, or maybe she has antibodies, we call them, against him. So basically, their immune systems are not a match. So then what we do is we take, and in this situation, the mom and the son, they have the same problem. So then we take the kidney from donor number 2, which is the husband, and give it to the son here. And then we take the kidney from the mother and give it to the wife, and then everybody is happy. So that's called paired exchange donation. And this is from the National Kidney Registry. We are part of the National Kidney Registry, and it's easier to facilitate those transplants if you do it nationwide, because then you have a larger pool of donors, and you can actually provide the best kidney for your loved one this way. Because if he can't take your kidney directly, then we match him with another matching kidney. So we match him with, we could say we want it to be from, if it's a young kidney, you would say, well, he's a young recipient, he's 20 years old or something. So then we can look for that. We can say we want it to be not more than 30 years old, the kidney. And then we match the immune system, we match the blood type and everything. So this is a very good opportunity to give your loved one a very good kidney that will last the longest possible. Yes, go ahead.
I just want to clarify, that's not the same family. Those were 2 different families.
Yes, so those are 2 different families. This is husband to wife, and this is mother to son. 2 different families, and they don't have to know each other even. And so the husband and wife maybe live in Wisconsin, and the mother and son live in California. And we can still get that kidney from the mother. She would donate in California, so we get that kidney from California to Wisconsin to transplant here. And the husband would donate his kidney here in Wisconsin, and we ship it. We take it on a plane, and we ship it to California and transplant it there. Okay. So altruistic donation is different. Altruistic donation, when someone comes and says, I have a friend, or I known about someone who died from kidney disease and no one could help him, and I would like to help anybody. And that is called altruistic donation. And altruistic donation is great in the setting of having an exchange program like we were talking about the National Kidney Registry. And the reason why is because those donors, called non-directed also we call them, they can actually facilitate big chains of transplant. So they can start the chain. Now, the good thing about the exchange program also is that there's a lot of people who have antibodies. So it's hard to find a kidney for them. And they're waiting for years on the deceased donor waiting list. And then a donor comes and they still have antibodies against that donor. When you have an exchange program that big all over the country, then you can actually give them a kidney that matches their immune system so they don't reject it. And altruistic donors can actually start these chains. And these chains can go up to 30 transplants. So one person who donates their kidneys, they can actually help 30 people on the list. And the way this works is this. So if you have a Good Samaritan donor or an altruistic donor who donates here, and then basically that donor donates to this recipient, and then that starts the chain. So basically you have someone who is waiting for a kidney transplant, or they're waiting for a long time. They do have a donor, but the donor is not going to donate until the recipient gets a kidney. That's how it works. So we try to actually give the recipient a kidney first, make sure that they have a recipient before the donor donates. So for example, if a mom wants to donate to her son, but her son has a lot of antibodies, so she can't do that. So they've been waiting on the National Kidney Registry for 6 months and not finding any match. So then someone comes and says, I would like to donate to anybody. And then you put them in the pool, and you find out that this donor actually is a good donor for that son. So he donates to him, basically, and then the mom would donate, but that goes through the National Kidney Registry to someone else. And then that basically starts that chain of donation through that. So how much time? Okay, thank you. So now after we talked about that and we understand the importance of living donation and how it saves lives for people on the waiting list, and the importance of that is because we have a huge shortage. Now we're going to talk about the implications for the kidney donors, and I'm going to talk about the long-term implications first. So the most important question is, if someone donates kidney, can they live with one kidney? The answer is yes. So what we do is we evaluate the donors extensively. We make sure that it's safe for them to donate. So they have to have a supernormal kidney function. That's number one. That's very important. Now once they donate their kidney, the other kidney grows in size in order to compensate for the function of the other kidney. They are going to have, after we make sure that whenever they donate, they will have a kidney function that is normal after they donate. Now this normal kidney function is not like their kidney function before they donate. It's a little less than that. It's about maybe 10 to 25% less, but it is still a normal kidney function that they can live with for the rest of their life. And we make sure that that's the case by evaluating them and making sure that the kidney function prior to donation is actually adequate. So now there have been many studies looking at that situation and looking at donors and comparing donors to the rest of the population. Now when you compare the donors to the rest of the population has healthy people, people who are not very healthy, so it's a mix of things. Now when those studies were done, they actually showed that people who donated kidneys compared to people who did not donate from the rest of the population, the donors actually had a better outcome. So their survival was better, their incidence of kidney disease was a little less than the rest of the population, so those were very positive numbers that we got when we did those studies. Now, when the newer studies were done looking at people who actually, and I'm just going to explain this. Again, don't look at the slides, look at me, okay? There's a lot of medical stuff there, but I just wanted to make sure that you understand that what I'm saying, I'm not making it up. It's based on studies. That's why I have the slides, but I want you to look at me so I can explain it. So so the newer studies we did is we compared the donors and we tried to match them with other healthy people because the donors are very healthy people. And that's what we want. We don't want to get a kidney from someone who's not healthy, right? We talked about that. We said they should not have diabetes or kidney disease or whatever. So we get healthy people. So if you compare those to other healthy people that are as healthy as the donors, but they didn't donate their kidneys, we found out actually if you follow them for 20 years, 25 years and a longer time, that actually donors do have a small increased risk compared to other healthy people to develop kidney disease, okay? The risks are small. We're talking about 1 in 1,000, okay? Small risks, but it's per these studies, because we studied thousands and thousands of patients, then we got to that number that there is actually an increased risk in donors compared to other healthy people, okay? So the short-term surgical complications for kidney donation, most of the surgeries most of the surgeries that we do, maybe 99% and even more than that we do at St. Luke's Hospital are laparoscopic surgeries. So we have smaller incisions and fast recovery time. Our donors can actually go home the next day or 2 days after that because it's a laparoscopic surgery. So we try to minimize the risks to the donor, of course. And a lot of planning, before surgery happens, that we study their imaging, their CAT scan, we make sure everything is good to go before we do that. So these risks are basically compared to other surgeries that you would do in the hospital, are very low risks. So wound infection is low, and then bleeding, injury to other organs during the procedure, blood clots in the leg, so we ask them to walk immediately, even the same day, and then having a pneumonia or infection in the lung. Donor death was very low. In many studies there were 0. And then incisional hernia, which is a hernia at the site where they took the kidney out. So okay, so this basically concludes my part of the presentation. I'm going to hand it to Jeff, but any questions for me? Okay, sounds good. So Jeff, you're up next. Laser, and those are the slides. Go back.
Okay. Good afternoon. My name is Jeff Klister. I'm a nurse at St. Luke's Medical Center, and I'm also the living kidney donor coordinator at Aurora Healthcare. To recap what Dr. Hussein was talking about, there are 3 different types of donors: the biological related donors, unrelated, meaning friends, spouse, and then the altruistic donors. Potential donors, they must initiate communication with me. So they need to call me in order to get the evaluation process started. We go through a telephone questionnaire, and what I'm doing, well, asking questions and getting answers is kind of following our protocol to make sure the potential donor is, fits our criteria. And some of the criteria is their age, 18 to 70 years old, no history of diabetes, no uncontrolled hypertension, no active cancers, no history of blood clots. Another one is a BMI of greater than 35. We would need to wait until they, lost some weight. Active HIV, and of course, the suspicion, the donor coercion of, it is illegal to, try to sell your organs. So that's kind of the information I'm looking for. If everything looks good on the telephone questionnaire, I can put orders in for the initial blood draw. And that would be ABO, which is looking for the blood type, and the HLA, which is the genetic part of it. I'm going to skip to the next slide. And here's a little graph. Once I get the blood results, if the donor and the recipient are compatible, we can start the donor evaluation with an internal surgery. If they're not compatible, we do have the option of the paired exchange program with the National Kidney Registry. Either way, we can start the donor evaluation, and it's my job to coordinate and schedule appointments, with all the criteria listed here. So we kind of have this divided into phases. So of course, phase 1 would be consenting with the donor, allowing us permission to put the donor, through the donor evaluation, and then scheduling the tests. So that would include additional lab work, urine studies, chest x-ray, ultrasound, an EKG and an echo. And then also the donor is required to have the preventative maintenance, health maintenance, their scheduled PAPs and the mammograms and the colonoscopy if they're 50 years or older. Also, phase 2, excuse me?
Who pays for donor?
The donor evaluation testing actually goes to the recipient's insurance. Of course, the preventative maintenance, the mammogram, PAP, and colonoscopy, that would be up to the donor's responsibility. So once the initial testing is completed, then we can start scheduling appointments with the multidisciplinary team members, including the donor advocate, the pharmacist, registered dietitian, financial coordinator, and the social worker. So once those appointments are completed, then I can schedule an appointment with the nephrologist and the psychologist. Once that's complete, then we can take this case to the selection committee review board so the team members can review all the test results, all the recommendations from the team members, and if there's no issues, then I can get a final approval for the donor to finish the donor evaluation with the final phase. And the final phase consists of a CT scan and then an appointment with their surgeon, the donor surgeon, and the recipient surgeon also would like to talk to the donors and explain the surgery and review the CT images. And then I can present a case for a final approval to the selection committee review board. Once I get a final approval, then I can give the donor and the recipient a call and tell them that they've been approved and that we can set a surgery date. This is just more details about the extensive testing that we do, which is part of phase 1. And the multidisciplinary team members again. And then the medical consults with the nephrologist, psychologist, and the surgeons. And does anyone have any questions about the donor evaluation or the coordination of? Yes?
How long is that whole process?
That is one question I can never answer. It all depends on two things. One is the donor's availability. A lot of my donors are in the workforce. So they have, we have to try to schedule these appointments so, around their work schedule. If they can take a day off, then my scheduler and I try to coordinate as many appointments as we can in that one day off to help go through the evaluation. Yes?
Jeff, how long does it, if someone is an altruistic donor or if my donor lives in another state, could you just talk a little bit? Because I understand how if I live in the area that might work, but how does a transplant center deal with maybe someone that is out of state and getting started?
I do have a lot of out-of-town and out-of-state donors, and what I end up doing is the initial blood test, what I'll do is I'll ship out a blood kit along with physician orders, insurance information, lab instructions, and a return shipping label, and ask the donor to ask their primary physician to fill the blood kit, and then the donor can ship the blood kit back to us so we can process it. I also then write a letter to their physician asking for their cooperation to if they can have some of the testing done with their primary physician to try to eliminate the number of trips they'd have to come to Milwaukee. So the lab work, chest x-ray, ultrasound, echo, EKG, I mean that can be done with their primary physician as long as I get their agreement that they'll cooperate with us. Once the initial testing is done, the donors will have to come to St. Luke's to meet with the team members along with the surgeons. Yes?
What happens, and I don't know if you'll have to repeat this or not, so I'll try to say it really loud. What happens if I have 2 or 3 people that I work with or worship with and they all want to get tested to maybe see if they could be a donor? How do you handle that as a transplant center?
Well, I'm happy to handle that because that's great. So those those recipients are fortunate to have a number of donors call me. What we end up doing is I will go through the telephone questionnaire with everyone. I will order the initial blood test so we can look at the results along with a health history questionnaire. Once I have that health history questionnaire, which is completed by the donor and mailed back to me, I collect all those along with their lab results, and then Dr. Hussein who's our medical director, will review them and choose the best candidates to start the donor evaluation. The remaining donors, we do use as a backup, just in case we would find something wrong that the initial donor wouldn't be able to donate.
Jeff, I have a question. Dr. Hussein talked about paired donation. So if my donor doesn't match me, does my donor get the same workout and get placed on the list for paired donation?
If the donor and the recipient are not compatible and they elect to go through the National Kidney Registry, the donor would go through the same donor evaluation as an internal donor would.
Thank you.
Yes?
How long does the donor have to wait before they can return after the surgery?
Can you repeat that question?
Sure. The question is, how long does the donor have to wait in order to go back to work? The average length of stay in the hospital for donors is anywhere from 1 to 3 days. Recovery time is anywhere from 3 to 6 weeks, and that really depends on what type of work they do. I've had donors go back to work 3 weeks after surgery. Granted, they work in an office or a desk job, and of course some of my donors who have a physical job working in a factory, they're going to take up to their 6 weeks because of the lifting restrictions.
I have a question. So if a person has ever been treated for cancer in their lifetime, is it impossible for them to ever be a living donor?
It's not impossible. The question is, if someone has had cancer, a history of cancer in the past, would that eliminate them from being a donor? And the answer, that is, I actually reviewed case by case by our medical director, and it depends on what type of cancer, how long ago it was. So that's kind of
Doesn't automatically eliminate it, right?
correct.
Okay, and then one other quick question. From the time that a person passes, because I heard different things that basically to be a donor, you got to die in a hospital. What is the length of time from time of death to that you would say, oh, I called the ambulance and I would like them to donate, but is there, I mean, it's pretty much when they're dead.
And I'm going to refer that question to our one of the next speakers.
Okay.
She's the organ procurement nurse. Yeah, so that would be a question for her. So any other questions?
Jeff, maybe you can just repeat that. If people that are watching online have questions, they can type those in at any point, so they don't have to wait, and then we can always circle back with you too.
Okay.
So.
Well, I'm going to introduce our social worker. And this is Jessica. Oh, you don't have any slides, right? Do you? Yeah, that one.
Hi, so again, I'm Jessica. I am a social worker with the Kidney Transplant Program at Aurora St. Luke's. I also work in the abdominal clinic, so I occasionally will work with our liver patients as well. I'm a small cog in the whole big wheel, but I at least wanted to present to you all my role, at least in the transplant workup process, and also the resource that I can be potentially to people who are donors or considering to be donors. So in a small nutshell, my social work role, Jeff mentioned that I kind of fall in the middle of the evaluation process along with a lot of the other disciplines. I do complete a full psychosocial evaluation with all of our proposed donors. It's actually a quite lengthy evaluation because we really want people to know what they're getting into, really be committed, and show that they've really given the thought necessary to really go through with the full process. I am part of the selection committee meetings that have been briefly touched on, and I do feel that I can play a role as an advocate for people who want to donate in those meetings. And then, like I said, I am a resource. I don't think personally that I get tapped into enough for that, and I'd like to see more of that. I am accessible through the clinic for any additional needs. Lingering questions, concerns, people just need to kind of just rebrief, go through things again. And then another thing I always like to encourage people to do prior to surgery is advance directives. So like your power of attorney for healthcare. So what that document does is it designates others that you trust, that you've had conversations with, that can step in if you are not able to verbalize to us what your medical wishes are at kind of the time of need. So social workers are more than willing through our clinic to assist with that as well. Just keep that in mind. And there's many documents. There's power of attorney for healthcare. There's a 5 wishes document. There's honoring choices. There's lots out there. So if you have questions about all the different ones and kind of what's right for you, again, available as a resource for that. So I want to touch in a little bit more detail on the psychosocial evaluation that I do. Key points, we go through background, personal history, your marital status, children, siblings, education level, work history. We go into a bit of detail about that. I touch on job and financial things. I think I'll leave that to Chris Carloni, our financial coordinator, to go into a little bit more detail. But we just make sure that you are aware that you are going to be out of work for a couple weeks. Kind of what your thoughts are about if you need to be out of work for longer than what you were planning. Have you talked to your employers about that? Have you talked to your employers about FMLA, family medical leave? So we just want to make sure that all these things have either been talked about or you know that it might need to be addressed. We discuss any substance use history, use abuse, anything that, again, may affect your ability to be a donor. Mental health history, if you have history of mental illness, bipolar disorder, depression, anxiety, if you're currently undergoing any treatment with a professional, with a therapist, we just kind of talk about what your status is there. We really try to assess your coping skills because a lot of times after donation, that kind of hits people then, that what they've really gone through, the gifts that they've given. We talk about how you handle stress just on a regular basis. So we go through a couple questions there. We review your motivation for your decision to donate. Make sure that you weren't coerced in any way to enter this, that you weren't bribed financially, that you are doing this of your own volition, that you've thought about, if you have another loved one who might need an organ, what are your thoughts about that? How do you think you'd react? How do you think you would feel if the recipient didn't care for the organ that you gave? How do you think you'd react then? So we pose a couple scenarios for you to really maybe think about if you haven't already, or just to see if you have thought about them. And then lastly, excuse me, we discuss the supports that are needed after donation. So you yourself, along with the recipient, will have some recovery. So we just need to make sure that you do have people at home that can support you, can help you as you yourself are healing from the gift that you've given. So, and then after surgery, you do get a visit from a social worker while you're in the hospital. We try to see people either same day or day after, again, to assess the supports, how you're coping, make sure you don't have any questions, concerns about going home, see if there's any more questions we need to address while you're in the hospital. And then if for some reason it seems like other follow-up calls might be needed, something after you leave the hospital, we're always available there to just kind of check in periodically. So that's kind of on an as-needed basis. So that's, in a very small nutshell, our involvement in the process. So, yes?
Can you talk a little bit, some people, especially in other parts of the country that are listening in, is some of the things that were described about the process, or especially the social work part, would you say in general that most of the things that you said would be typical critical, so there's always going to be a social worker involved in the process, no matter what the transplant center is at. So someone is always going to be interactive
Sure.
and have a social work.
Sure. Should I repeat the question?
Transplant center.
Do you want me to repeat the question?
Yeah. I probably talked loud enough.
I just will, just for giggles. So the question was, does this vary center by center, state by state, the involvement that social work will have, kind of what the assessment involves? And yeah, I've actually looked at a couple different tools. A colleague of mine actually have quite an interest in looking at the various tools that are out there, and I do find that our assessment is very similar to a lot of the other tools that are used. So I do feel like that is pretty consistent. And yes, the social worker is a part of the team, so everybody's just as lucky. So, yeah. Any other questions? Okay, I will pass it on now to Kelly.
Okay.
Good job. So maybe here. Can you hear me okay? Hi there, I'm Kelly Fenhouse. I am an organ procurement coordinator. Nursing is my background, ICU nursing. I work more on the deceased donor side of things. So I work with the living part of it, but I just kind of have a little bit of information more on the deceased donor part. So I would be the one that does kind of the logistics. So I get the organ offers when there's a deceased donor anywhere in the nation for any one of our listed patients at St. Luke's. And I work not just abdominal, so I do kidneys, livers, pancreases, and hearts. We do all of those organs.
If there's a Scott Seymour in the library, please come to the
One moment.
Thank you.
So those are the organs that we do at St. Luke's. So I'm involved with all of those. So I also get to call our recipients in. So if anyone is listed at St. Luke's, you'd be getting a call from myself or one of my 3 coworkers. So you would be getting a call probably from a cell phone number. So if anyone is listed, answer any random numbers. Please answer it, because sometimes we are tracking people down left and right. We've called dialysis centers. We've called mothers, fathers, brothers, sisters. You'd not be surprised. So answer your phones. That's all I have to say. So I kind of do logistics, get OR set, get planes, get cars, just get everybody where they need to be and make the transplants happen. So we're kind of the behind the scenes people that nobody really knows about. So then I think you had a question, and it was, how long can a kidney be out from a deceased donor? Was that your question?
Well, the issue is that I have heard that basically to procure most organs, you've got to basically die in a hospital. Like if a person is found deceased in the home, is there a time frame from finding the person, from time of death, that they would be allocated for any donations?
Yep. So basically it's just a donor has to be in, I think we could hear that. Was that question okay, loud enough? Okay, so basically when there is a deceased donor, they do indeed have to die in the hospital to be a donor. So say someone's found down at home and they're able to revive them, bring them to the hospital, they need to be in the ICU on a ventilator. So it's going to be a controlled environment for that donor to go to the OR. So it's not like a person comes in and they rush them to the OR. Basically they come in, they're managed in the ICU, they're managed by the critical care team. Sometimes these donors need a little bit of tweaking. They may have been down for 6-7 hours. That's kind of long, but they may be down that long, so maybe their heart's not doing so good. So we need to add some drugs. We need to add some medications. We need to kind of just vamp it up to get blood supply back to those organs and really make them good for transplant. So then the donor would go to the OR basically like any surgical procedure. So they get taken down to the operating room. There's teams that kind of fly in, drive in. Everybody kind of gets coordinated, so it's not a quick process. Sometimes these donors may sit in the ICU for a couple days to get them in tip-top shape for donation. Basically, that's kind of how. Does that answer your question?
Yeah, so you're saying that if a person is actually down and then they revive, no hope for recovery. You said about a 4-hour window,
Yeah, it's hard to,
depending on the health and how a person was found or whatever.
Yeah.
Okay, yeah, that actually that does.
Yeah.
Thank you.
So someone who's died in a car accident on the scene and is dead at the scene, unfortunately, cannot donate. They donate organs. They may be able to donate tissues, eyes, bones, things of that nature, but that we don't really coordinate. That's kind of another back channel. Does that answer that question? So I can just kind of take questions on anything with deceased donors if anybody has questions like that. That's kind of my role. That's it. Great. Thank you. So I was quick. This is Chris, and she is our financial coordinator, and she can give you a little bit more on that.
Well, thank you very much. My name, again, is Chris Carloni. It's a pleasure to be here with you. Who pays for all of this? Jeff kind of touched into a little bit for any individuals who are going through evaluation for potential living donor. Actually, the living donor pays nothing. It's the recipient's insurance that we will be billing for the charges for the evaluation. And if, in fact, there is a match, it would be then for the actual surgery. And then, of course, there's follow-up appointments that are going to be needed after the surgery. That's all going to be billed to the recipient's insurance. So as far as any potential living kidney donors, they are not billed. Their insurance, we don't even ask their insurance information. So as part of the evaluation that the living donor is going through, I will get the opportunity to meet with them, answer any of their specific questions. Everyone kind of comes, you know, with a different scenario, but basically this will all be explained to the living donor. In addition to helping the living donor out when a recipient is going through their evaluation, I will also be explaining to the recipient the importance, looking at their insurance coverage, knowing that it is the recipient's insurance that's going to be responsible for living donors. I also will be touching base into the recipient signing up for Medicare. Kidney transplant recipients are going to be eligible for Medicare, and Medicare does provide great coverage for living donors. I will be available after the meeting for any questions if anyone has a specific concern regarding the finances. Okay? All right, and Dr. Hussein.
Thank you. What I would like to do is I would like to bring our speakers back up at this time to take any questions from those of you who are listening online and those of you in the room specific to what we've been talking about. I know there was one question that was presented to me, and I'm going to present this to Kelly. The question was, what and how long can a kidney survive once it's been taken out of the body, and what is that process in the transport, and how does that work?
So kind of in a nutshell, I can kind of compare like deceased donation to a living donor kidney. So with a living donor, kidneys, and Dr. Hussein kind of talked on this a little bit, they do better because if you're in the same city, if you're in the same hospital, it can go room to room and be out of the donor into the recipient within minutes. The quicker that a kidney is put into the recipient, the better chance of survival and the longevity of it is much better. So with deceased donors, those donors, sometimes they could be in California, they could be, and we have to fly our team out there, fly it back, or it could get shipped to us and we have sight unseen this kidney, whereas with the paired donation, we know what's coming to us. We've expected it, we know what's going on, and even if it is across the country, it's going to get here faster. Everything is set, it's ready to go, and it can get in faster, whereas deceased donation, we may get it here, we may need to look at it, it's going to take a little longer. Sometimes kidneys actually go on a pump. So it can stay out of a body, ideally 12 to 24 hours max. The sooner the better. We say 4 hours or less is great. But the deceased donor really, I feel like I'm talking in circles now. The deceased donor kidney is out of the body much longer, basically, is the point there. So living kidney donation does better. Does that make sense? Okay, next question.
I'm just going to answer some questions again and see if anybody has any questions for me also. So basically a few questions that I was asked and I would like to explain a little more on. So The first one is about the actual surgery itself, and we did not have a slide to explain that, but the surgery for the living donor is mostly, and that's like, we try to do it 100% of the time, of course. However, sometimes if there's any problems that happen during surgery, they might have to do an open. But laparoscopic means that there are small incisions, usually 3, in the abdomen in these areas, and those are to put their scissors, the light, and all of that in order to see, and the scope, okay, the camera. There has to be a camera there so they can see. Now, when they take the kidney out, there's an incision that is just above the pubic hair line, so it's in the lower part of the abdomen, so it's hidden part, and the incision is usually around that long, okay, in order for the surgeon to take the kidney out, okay. So these incisions are in areas that, of course, the small ones in the abdomen are small that they're not going to cause a hernia, and the one down there is in an area that is covered by other layers of the body, so the chances of having a hernia there is less. And with that, the rate of complications are lower, of course, when we do that. The open surgeries in the past, the scars will be very long. That was in the past. We don't do that anymore. And the recovery would be much longer because of that. The other question that was relevant is, what if someone has a lot of donors, like 5 or 6, sometimes we get 7 even. So the way we do that is we, as Jeff has explained, we look at their medical evaluation, medical questionnaire, in order to make sure that they don't have something that is a contraindication to donation. But we also study their immune system. We have to make sure that the immune system is the best for that recipient, because the more you match the immune systems, the longer the kidney will last and the less chances of rejection and all of that can happen. The other question that I was asked is in a chain donation. So if you have someone going through National Kidney Registry and you have a donor and someone donates a kidney, but then the other people decided, well, they changed their mind. They don't want to donate, and that's okay. So if someone wants to donate all the way before they do the surgery, they can say no, and that's their right. We're not going to tell them, oh, why didn't you tell us before, or anything like that. So the solution to the problem is that we have the altruistic donors that can come forward and they can fill these gaps through the National Kidney Registry. And that's the benefit when you have a nationwide system compared to just having one hospital system. Yes, go ahead.
We have one from online from Grace, and she wants to know if a patient receives a liver transplant from a deceased donor and a transplant from a living donor, does the living donor transplant still retain its status as a better kidney?
Okay, that's a very good question. I'm going to answer it in 2 parts. So the first part is that if you have someone who receives a liver transplant and receives a kidney transplant from the same donor, so someone who dies, of course, you can't, so we have liver donation from donors, of course, but they take part of the liver. But if we're talking about someone who dies and you take their livers for transplants, you take a liver and a kidney transplant, that is a very good situation because they have organs from the same donor. The liver protects the kidney from rejection, okay? But if someone did not need a kidney at the time of liver transplant, they just got a liver, and then the liver survived and they lived 10 years, say, and then after that the kidney failed, so they needed a kidney transplant. Still, living kidney donation is the best if they have a donor. That is the best for them. Now, they're 2 different immune systems. They still need immune suppression either way, and they should be, that should be okay. So, yes?
One, we sat on the operating room table. When did you see living kidney donors? And the second question is, how do you decide which kidney to take?
So the first question again, sorry?
Other than being on the operating room table, when do you see the...
Oh, I see, okay. So I am actually a medical doctor. I don't do the surgeries by himself. So the surgery of the donor happens by a urologist, usually. So they're specialists in surgeries for the kidneys. And they actually do see the donors before, way before the surgery. So the evaluation team for the living donor, so her question was, I'm sorry if someone did not hear the question, is that when do the surgeon who does the surgery see the living donor? Do they see them in the OR or before that? So the answer is yes, they see them before that. So they are going to be seen by a kidney doctor, who's me, and other kidney doctors of the team. They're going to be seen by as the surgeon who's going to do their surgery, which is a urologist or a kidney surgeon, and they're also going to be seen by the surgeon who's going to take the kidney and transplant it to someone else, because there is also matching situations here. And the second question, how do you decide? Yes, so the way we decide is we look at the size of the kidney. We measure the size on the CAT scan, and we look at the volume of the kidney, and we take the kidney that is smaller in size, and we leave the donor the kidney that is bigger in size. That's how we decide. If both are the same, then there's anatomical considerations of the length of the artery, the length of the vein, and all of that. That's very relevant, because when we want to take a kidney, we want to make sure that the recipient gets a good kidney and a kidney that will not have problems with artery or vein and all of that. Any other questions? Yes, go ahead.
I haven't heard this addressed, but I'm on dialysis.
Mm-hmm.
Is there a waiting time?
Yes. So the question is, if you are on dialysis, and how the waiting time works. So recently, and that's last year, the listing for kidneys has changed. Before it was, when you get the evaluation, you're put on the list. Your time starts from the time that the committee decides that you're a good candidate for a transplant. Last year, things changed because there's a lot of people on the waiting list, and they've been on the waiting list for 7 years, and they're on dialysis. And those are the people that in need for kidneys quickly, so we can save their lives. So then the allocation, we call it, of the kidneys has changed. So people who are on dialysis, their time starts from the time they started on dialysis. So if someone has been on dialysis for 10 years and didn't know that he can get a kidney transplant and then comes to the transplant center, their time is already 10 years automatically. And that helps them a lot to get a transplant sooner. Because so the longer people are on dialysis, the more complications they're going to have from a heart standpoint and all of that. The difference between getting a transplant and being on dialysis is basically, and the most common thing, is the heart. Because the blood vessels, being on dialysis, they age. They have deposits of calcium and all of that in the blood vessels. That increases the risk for heart attack and stroke. The changes in the blood volume also affects the heart, so the heart fails on the long term being on dialysis. And that's why transplantation helps these people. Now, kidney transplant comes with its own complications. You know, they have to be on immune suppression medications. They have to go through the surgery and all that. But really, it is weighing the risks and the benefits here. If we think that the benefit of getting a kidney transplant outweighs the risks that are involved, then we go ahead and do it. So, any other questions? Any questions for the rest of the team? Okay, well, I'll give it to Cindy here so she can.
Well, great. I think the team from St. Luke's did an awesome job. I know that they'll, oh yay, it's a standing ovation here in the room. For those of you who joined us online, thank you very much. And for those of you in the room as well as those of you online, if you could take a few minutes. Those of you here in the room have a survey right now. Those of you online will receive a survey. We are working to make sure that all of our community ed programs, meet the needs of individuals that are interested in this particular case, living donation. So your thoughtful comments about tonight's program. I want to, again, acknowledge and thank Kathleen Springer, who's a member of our board of directors, as well as a manager at the St. Luke's program, Dr. Hussein, and the rest of the team for coming. It's like amazing to have all of these folks volunteer, bring their expertise. I want to call your attention to those of you that are in the room, as well as those of you who are online. We are doing a different program on living donation and a different aspect of living donation